Our next presenter is Benjamin Rasmussen, who's going to talk to us about what evidence do we have to support the case of telemedicine in wound care, so far focused on diabetic wounds. Thank you, Benjamin.
Thank you, Mr. Chairman. As told, my name is Benjamin. I'm a MD and a PhD student, currently writing my thesis about telemedical wound care. And I was asked by EWMA to give a brief presentation about evidence and telemedical wound care. So here we go. These are the subjects that I want to address. First of what is telemedicine, why telemedicine, evidence, my method, my result, a summary and a perspective, and then a remember. And let's begin. What is telemedicine? This picture actually explains it all. You have a physician and a patient standing in another room, another municipality, and the physician or the nurse are conducting or monitoring the patient via distance. Kidding aside, the American Telemedical Association has defined telemedicine as the following. Telemedicine is the use of medical information exchange from one side to another via electronic communication to improve a patient's clinical health status. And within wound care, we have different kind of telemedical solutions. We have the asynchronous one without the patient, often via still images. And we have the synchronous one with the patient, often via video or still images. And why is telemedicine so important? There have been many slides about the aging of our population, and this is from prb.org that shows a quite steep slope on the elderly with chronic diseases. And especially my government has announced telemedicine as the golden goose. It will be the savior of all our problems and all the healthcare problems in the future. I actually don't think there is any evidence about that in any field of telemedical research, COPD, wounds, ICD, etc. So evidence, I will not talk that much about this pyramid. I know Patricia Price held an excellent speak about evidence, and I will mainly focus on RCT and cohort studies. And the basic is, desto higher the tube, the better the evidence is. So my method, I conducted a literature research. I used these four libraries, the Cochrane Library, Medline, CINAHL, and Embase. And I included studies with the following keywords: telemedicine, eHealth, and wound care, or wound, ulcers, etc. I only included studies in which were with real outcomes, patient outcomes, organizational, economical, and the chronic wounds, not acute wounds as burns, etc. And I did not take in single case reports and test of technology feasibility. There are a lot of studies showing that you can use still images to assess wounds. So I haven't included those. This was actually my search. It based on 486 articles in total. And after title review, I got 226. And after duplication, 137. In retrospective, I should have done the duplication part before the title review, but you'll learn. And after at the bottom, I got 26 studies after looking at the abstracts. So here are my results. Those are divided by year, 2000 until 2014, with a peak amount about 2004 and 7. The studies were as followed: 9 case series, qualitatively studies was 6. This also included surveys, and 6 RCTs and 5 cohort studies. And within these studies, there were different kind of technology used. As you can see, 18 of those were store forward, still images transmitted via a online communication tool, an online database, etc. And the live video conference was 8 of those. And let's start with the RCTs. 6 studies, and one of them I couldn't, or it was a qualitatively RCT, so I couldn't really define the patient number. So this is actually the total of RCT we have on telemedical wound care. And in total, 144 in intervention group and 149 in the control group. Within this, we have different kind of technology, so it's not comparable, and transferability is not an issue, or is an issue in this case. We have 3 different kind of technology used, or methods used in the literature. Going on to the cohort studies, we have 154 intervention patients and 242 controls. Again, there are only one study. I couldn't find the actual technology. It wasn't described in the article, but it is more the same in the cohort studies. So when we address that different kind of technologies are in use, isn't it also important to address different kind of wounds? I don't think it's okay to transfer the result from Venice also to diabetic, because they're so different treatment methods to these different kind of wounds. And many of the studies are using mixed etiology ulcers. So that's a problem. But moving on to the clinical part, 1, 2, 3, 4, 5 studies actually had a real clinical outcome. And I've lined them up like that. This is the negative, this is the positive, and one in the middle. Terry et al. Showed no statistic significant between groups and a poor performance in the telemedical group. Wilbright et al. Show no difference within the groups. And all these authors shows a faster healing and significant different healing rate. So that's positive. But in total, 103 patients in Terry's, 140s in Wilbright, and 293 patients in the 3. As you can see, the one marked with an R up here is randomized control trials, and those with the C is cohort studies. In general, the staff acceptance was high, satisfaction was high, and I couldn't find that much negative literature about staff and telemedical wound care. So overall, very good. And this is the patient. One of the patients, or several of the studies had that the patient has some concerns with lack of direct communication with the physician. And that differs within the technology assessment, but it's a general tendency that people will like to see their physician once in a while. Overall, there was high acceptance, high satisfaction, etc., etc. The economy part, I'm not an economist, but all the studies showed potential cost saving. I don't know what that is, but potential cost saving may implicate that we can earn or save some money in the future. The studies that have shown faster healing rate, etc., has also shown fewer visits to GPs, fewer visits to outpatient clinics, etc. And that will mean saving in the hospital and the municipality, and not least with transportation. So in summary, I don't think that we have the evidence to back up that we can treat our patient with telemedicine yet. Staff, patient, economy, organization, maybe there's a clear tendency that it's okay, but the quality of the literature is not that good. So perspective, I have found these 3 studies on clinicaltrials.gov, and the first one is actually my own, and we are soon to be reporting 200 patients in the intervention group and 200 patients in the control group, and using store-forward technology. Then we have a Norwegian study with 279 patients. I couldn't find the randomization key, but this is an RCT with 279. And then a France study with 64 patients in an RCT. So in the future, we'll see some high-impact evidence within this field. So hopefully, they will give us some more insight about evidence and telemedical wound care. And last, my remember. This picture illustrates it. and we need to ensure that the clinic is okay. We need to ensure that we're treating our patients good. We are not thinking, we don't have to think about economy, we have to think about the patient, and is this technique, this technology safe for our patients? That is the first and the keystone in telemedical wound care. Thank you.
We have time for some questions for Benjamin. Yes, Diane.
Benjamin, what an interesting presentation. So, to wish you well with your PhD as it develops. You're clearly from Denmark. I know there have been a lot of presentations from Denmark today. Can you tell us about the international nature of the literature search and where, in fact, wound management is happening around the world? So a little bit of kind of background to those, either to the 26 or to the greater 200 that you discarded. How international is wound management using telecare?
Much of the literature is actually from, not much, but some of the literature is from Denmark. And a general tendency is that the European nation has more pilot studies than the US, and a lot of studies also from the Australian country. So, yeah, that's the broad perspective.
Thank you.
Okay.
It's good to have that insight.
Hi, thank you very much for a great presentation. Big difference in the use of technology. A lot of people seem to be using store and forward, and very few people seem to be using video technology. Is that a reflection of lack of ability in technology or lack of development in the video world?
I don't think so. Those study was included because of my criteria. So there's a lot of feasibility studies among video conference with proof of feasibility of technique, but not real clinical studies. So I think that is the main problem, that you haven't taken the feasibility studies to the next level within video conference.
Sorry, just to follow that on. And therefore, would your conclusion be that you need more clinical studies using video technology?
Sure. We have to evaluate that way as well. I think video technology, video conference, is a supplement to the store and forward technology, so sure.
And therefore, how are you going to induce more clinical studies using video technology?
That's a good question. Do either of you have any ideas? I don't. I use store forward technology, and I know that some departments are using clinical video conferences, but not in direct care with wound care. So,
well, I ask because I'm from a video technology company.
Okay.
And we are only just now coming into the telemedicine world,
Yeah.
and trying to reach the right people to be able to say, here, we now have this technology, take it out and use it, and do some clinical trials, you know, put the technology onto tablets, onto mobile phones, and come back to us so that we can provide the evidence of outcomes and cost reduction and how it benefits the patient experience.
The store and forward technology has some benefits by being store forward. You don't need to have participators in each side at the time. In a daily outpatient clinic, it's often difficult to match the time with the municipality nurse. So I think that is one of the major problems with video conference and wound care.
Unless you can record live as well.
Sorry?
Unless you can record and forward that piece of recording.
Sure, a video, yeah. That could be an option.
All right. Any other questions at all? No, thank you, Benjamin. Very interesting presentation.